All right, so now we did our verbal secondary assessment. We're going to do a modified secondary assessment. This is going to be a physical portion to our assessment. Based on our chief complaint, for example, chest pain, we're going to go ahead and physically look and assess the chest itself. Okay. Now, we're going to use this method of inspecting, palpating, and auscultating. Now, when we inspect, we're going to visually inspect the area in question. So once again, using chest pain as our example, we're going to go ahead and assess for any scars. Do I see a surgical scar coming down the center of their chest? That's a good indication that they had some type of open heart surgery. So I'm going to ask them, sir, ma'am, what's the scar that's on your chest? Ask them about it. They could have already told you back when we asked about past history. We're going to look for any patches. Do I see any patches on them? They could be medication patches. They could be a nitroglycerin patch. It could be a fentanyl patch. It could be a lidocaine patch. There's multiple patches that are out there that medications are delivered. So we're going to assess for any patches. Do I see any trauma? Any trauma to that area in question? Do I see bruising? Do I see hematoma? Do I see a hole? Do I find out that this is actually a gunshot wound or a stab wound that the patient didn't mention? Believe it or not, that happens. So look for any types of trauma. Do I see a pacemaker? Now a pacemaker is going to look like a raised area on their chest. It could be usually on the upper left or even on the upper right. It's very noticeable. You can see a raised area on them. And then ask, what's that lump? They can imply that it's a pacemaker, but understand that that pacemaker, that lump could actually be a vagus nerve stimulator as well going into their brain. So go ahead and ask them what that is. Now for other medical complaints such as allergic reaction, we're going to look for hives. I'm going to look for swelling. Do I see the area in question? Do I see the bee stinger that stung the patient? So anything else that could be noticeable. Now I'm also going to look for any tubes or wires. Patients can have feeding tubes. They can have tubes coming just below their belly button. They can have basically a drainage to drain urine. So they can have a colostomy bag. They can have multiple different tubes, wires, bags to them. Ask them what that is. Any wires. Sometimes patients will have wires as far as any type of cardiac devices, advanced cardiac assessing devices. They can have a Holter monitor. They can have various different types of assessing devices. And symmetry. In regards to if they have some type of extremity pain, if they have some type of issue, their face is feeling numb, maybe some stroke-like issues, we can look at the symmetry. Does both sides match, or is there something wrong? You know what? Looks like that right shoulder looks very deformed and very abnormal compared to the left. So we're going to check symmetry in the area in question if it's applicable. We're going to palpate. We're actually going to put hands on the area in question. We're going to look at the area of chief complaint. Now, for chest pain, we're going to go ahead and push front to back, and then we're going to push side to side. Do I elicit pain from that patient? Commonly, patients that I can elicit pain upon palpation, commonly it could be something else other than a cardiac condition. However, there's still a chance it could be a cardiac condition as well, so we're just going to document it and report it to the hospital. Now, with any type of range of motion, ROM means range of motion. So we're going to have the patient twist around. Does that cause pain? Any exertion? That can also indicate possibly something else, but once again, it could also be cardiac. So we're just going to go ahead and document it and report it over to the hospital. Now, if it's an extremity, so let's say somebody's having shoulder pain from a fall, we're going to see how much they're able to move their arm. Do they have good range of motion? Sometimes, very commonly, patients with shoulder pain from a fall, for example, they're unable to really move their arm out or up or any other direction. So we would document it as limited range of motion. Distal PMS, pulse, motor, and sensory. Distal pulse, motor, and sensory. We'll talk about that on a different day, but we're going to look at distal pulse, motor, and sensory of the extremity in question. If somebody's having shoulder pain, we're going to go ahead and check distal PMS. Now, any type of crepitus. When I palpate the area in question, do I feel bone-on-bone crunching? That kind of gets back into trauma a little bit here. But with crepitus, does that feel like an obvious fracture? It's one of those the patient's going to tell you that it's going to hurt a whole bunch. Okay? So be careful how much you palpate the area. If somebody's already telling you that their shoulder hurts, be careful how much you sit there and palpate it. Okay? We're not trying to intentionally hurt them. Okay? So just be careful. And then as far as auscultation, now the first area, we're going to assess the second or the third intercostal space along the mid-clavicular line bilaterally. Bilaterally means both sides. Now, in regards to the intercostal space, if you feel your clavicle, roll your fingers down just a little bit, you're going to feel the first intercostal space. As you continue to roll your fingers down, you're going to feel the rib followed by another space. That is the second intercostal space. Now, mid-clavicular line along your clavicle, right down the middle of the clavicle, comes straight down. That's going to be the first area that you're going to listen, but we said bilaterally, meaning both sides. You're going to do the same thing on the other side and find that same second or the third intercostal space. And we're going to listen bilaterally, meaning we're going to have the patient take a breath in and out. The second area is going to be the fourth or fifth intercostal space along the mid-axillary line bilaterally. Now, in regards to the mid-axillary line, it's going to be a line kind of hitting the patient sideways along the armpit. Okay, this is going to be the mid-axillary line. Now, typically, the fourth or fifth intercostal space can be commonly found if you draw a line straight out from the patient's nipple, draw it out. That's going to be about the fourth or fifth intercostal space. You're going to place your stethoscope right there. Don't forget, bilaterally, meaning both sides. The last place, we're going to listen to the inferior aspect of the scapula bilaterally. So you're going to take your stethoscope and you're going to auscultate just below the scapula, at the point below the scapula. You're going to listen to that both sides bilaterally.